Welcome. I'm Katie Thompson, a registered nurse and international board certified lactation consultant. Today I'm going to present my clinical project to you for my synthesis course in the RN to BSN program at University of Kentucky. The title of my project is In-Hospital Breastfeeding Support. But before I get into that, I want to give you a little bit of background of how I chose this project. I started out my nursing career as a newborn nurse at a hospital in Paducah and slowly transitioned over to lactation support. This last fall, I transferred to a sister hospital here in Lexington as a lactation consultant. Since I've been here, because of things I've seen and things that I've heard, I feel like there are a lot of areas needing improvement in the lactation support area. Also, I have not been as comfortable in the entire department here as I was in Paducah because I just don't spend much time there like I did there. So what I wanted to do is pick a project that would take care of both of those needs that I have. Do a project that will help the breastfeeding support area here, and then also get me a little bit more comfortable with the rest of the department. So what I decided to do was spend my clinical hours with nurses throughout the department, like a labor home nurse, a newborn admission nurse, a nursery nurse, and a postpartum nurse. And I did also spend some time in the NICU. And then at the end of that, evaluate the process flow of a breastfeeding infant from the time the mother shows up in labor and delivery until we discharge them to home. The objectives, obviously, are to get to know the department better, identify improvement areas where we can actually put actions in place to improve our support so that our mothers will be more successful breastfeeding and our infants will be healthier. This is actually the process flow evaluation, and I'm sure you can't read it, but I'll talk through the major points. But what we have is up in the top left corner, we have a mom that walks through the doors of the labor hall and is pending delivery. And when she's admitted, we ask her, do you want to breastfeed or bottle feed? And if she says bottle feed, that's the end of the conversation and we move along. If she tells the admitting nurse that she wants to breastfeed, you would hope there would be a little education that goes on there as far as what to expect with breastfeeding for the first few days and hours, and then she moves along through her labor. And depending on whether she's going to have a C-section or vaginal delivery, the flow gets a little bit different. The C-section delivery is along the top and the vaginal delivery is along the bottom. The only difference is that if a mom has had a C-section, she obviously goes to recovery, the infant goes to the nursery, and then when the mother's ready to have the baby back with her, the baby goes back to her. With a vaginal delivery, the baby actually just stays with the mother if the baby's stable and the mom's stable. And we're really good at this hospital. As soon as a baby is delivered, or as quickly as we can get a C-section baby back to their mother, we place these infants skin to skin with mom. The research shows that infants who are placed skin to skin, and that means just down to their diaper on mom's bare chest, are much more prone to show interest in breastfeeding in the first hours. And if a baby breastfeeds more in the first hours, they are also more prone to nurse better as time goes on. So even if it's C-section, we get that baby back to mom as soon as possible. And then when the mothers are ready and everybody's ready to come to the postpartum floor, both mother and infant come to the postpartum floor together. And then our goal is, as soon as possible, a lactation consultant will meet with that mother to go over some initial breastfeeding advice, find out if she's having any issues, and consult her any way that we can. We also have a breastfeeding video that we show all of our mothers. If a physician deems that he wants the mom to have a lactation consultation, no matter what's going on, or if she has a special need, he will write a consult and we'll see that and we'll go see the mother in addition to that initial visit. As the mom is a patient on the postpartum floor, if she feels like she needs help, she will normally call out to her postpartum nurse, and hopefully the nurse will provide what support she can. And then if she feels like she needs a consult, if we're not doing good, we're not being successful here, she will consult the lactation consultant. And then we will continue to work with her until she's successful breastfeeding. Now, if the breastfeeding issues go on longer than 24 hours, normally we would get the pediatrician involved to see what they want to do. but hopefully with work from the postpartum nurse and the lactation consultant, when the baby and mom are discharged to home, breastfeeding will be going well. What you can see up here, with every little star, this is where I identified a specific problem in the education area in the labor hall. When we actually go to breastfeed the baby after delivery, the whole lactation consultation thing is a problem area. The physician involvement in breastfeeding can be a problem area, and then also the postpartum RN support. I'm going to go into these in a little bit more detail on the next slide. Number one, that early breastfeeding education. Like I alluded to when we were looking at the flow chart, if a mom says she's formula feeding, she gets no education. If she says she's breastfeeding, she gets very little education in the labor hall. Early breastfeeding assistance after delivery, not happening so much. And I'm hearing this from the patients, and also from some of the nurses are telling me that too. The postpartum RN support for breastfeeding, they're also telling me it's not as it should be. Our actual lactation support for breastfeeding is not as it should be because we have so many patients. And then the physician, it's a culture thing that we've got to deal with. And I'll talk about these in a little more detail in the next slides. The number one area, that early education, like I said, if they're not breastfeeding, we just say, okay, fine, go formula feed. If they're choose to breastfeeding, we really don't tell them anything in the very early admission period. And when I say we there, I'm talking about the labor hall nurses. So my proposed solutions for this is that we will develop a benefits of breastfeeding handout that can be given to all moms, even the non-nursing moms, to let them make an informed decision so that they know the risk of not breastfeeding. And then also to give all of our breastfeeding mothers early tips for what to do right after delivery in the next few days while she's in the hospital. Number two, early breastfeeding assistance. And like I told you, many of the labor hall nurses just don't provide assistance unless a baby just magically latches on and nurses, or unless we've got a second-time breastfeeding mom. It very often just does not happen in labor and delivery. And again, the evidence shows babies who breastfeed early typically do better as time goes on. My proposed solutions for this is we need to determine if it is the labor hall nurse's responsibility to give that early education. And if it is, we need to train them how to do it and give them the tools that they need to do it. If it's not, we need to consider hiring additional lactation support staff so we could actually be in the labor hall to provide that education. The next thing, on the postpartum floor, I heard from a lot of postpartum nurses that they just don't have the time to provide lactation support to their patients. Most of them will just directly call the lactation consultant anytime a mom calls out for breastfeeding help. And then also, some of those nurses, even though they might have time or might feel like it's their job, they just don't feel adequately trained to do that. So my proposed solutions for that are to decide whose responsibility is it to provide the initial breastfeeding support. And then if we decide that it is the postpartum nurse, we need to be sure that they're trained and feel adequate to do that. And then also, we need to get better interaction between the lactation consultant and the postpartum nurse to decide who's going for support when. The next area is the actual lactation consultant support. And what happens here, like I said, a lot of these nurses on the floor don't feel like we are able to provide the support that we need to because they think we should provide all lactation support to all breastfeeding mothers, and sometimes it's just not possible. 4B here is how we feel as lactation consultants. We may come in the morning and have 8 to 12 brand new patients that need to be seen right away, and very often with a brand new patient we'll be an hour in their room, and then we may have a total of 25 breastfeeding patients, so it just becomes an impossibility for us to do all things breastfeeding. And so we need to decide that, who's going to do what, and then we need to establish that if we can't hire additional lactation support personnel, how we're going to get that help from the floor nurses, or maybe even the techs. Number 5, and this is the culture thing, very similar to what we read about in the Why Hospitals Should Fly book. what I found with this, there is absolutely no consistency in what our physicians are telling our breastfeeding patients, either the obstetricians or the pediatricians. So they're giving them different advice as far as how long to breastfeed, when to breastfeed, how often to breastfeed. And then they're also really inconsistent with interventions that they take when an infant is not doing well breastfeeding. So if an infant's lost too much weight, some of them will require supplements, some will say, let's wait a day. And then they all choose a different percent weight loss to choose to do interventions. So it's just really inconsistent. And then also, in some of the information that they're actually giving to our patients, the written information is not accurate. It is not evidence-based. So my proposed solutions are to get our hands on every piece of breastfeeding-related information that's being given to our patients and be sure that it's evidence-based. And try to get our physicians to agree on a standard protocol, a standard instruction that we're giving the patients, what we're training them on, and then also the interventions that we take when a baby is not doing well breastfeeding. And I could envision a meeting very similar to what Nance talked about in his book, that we would get all the pediatricians in the room and show them all the different ways they do things to make them understand that everybody can't be right, everybody can't be doing this evidence-based, and then encourage them that, you know, with our support, that we could get information for them so that they could use standard protocols. And so this is the detailed action plan, you know, how we're going to do that. We're going to develop a breastfeeding, benefits of breastfeeding handout that would be given to every mother. We're going to actually develop early breastfeeding tips that whoever does this can go over with the moms in the labor hall. And there's detailed actions all the way down through here. Develop standard breastfeeding information to give to patients and standard intervention protocols for our physicians. And then there's other more detailed things that kind of address the problem areas, like we need to include our physicians in our monthly lactation newsletter. And then I've got the specific names of who's going to do that action and when it's due by. And what we would hope to see when all of these actions are taken, and I believe all of my actions are hopefully going to be put in place by this next spring, that certainly we'll have much better consistent breastfeeding support. We'll have higher initiation rates of breastfeeding because, you know, some of our non-nursing mothers may choose to breastfeed after they see the benefits. Hopefully we'll have our exclusivity rates will go up because we're providing the support so that moms don't give bottles unnecessarily. And then also, we'll have, obviously, our patients are going to be happier because they're not going to be so confused by the different things everybody's telling them about breastfeeding. And then ultimately, we're going to have healthier babies. My last slide is just the references I've got for the evidence-based practices, and there are many of them out there. And I just want to thank you for hanging in there with me. I've enjoyed getting to know all you guys, and if you have any questions at all, just respond on Canvas or send me an email, and I'll be glad to talk to you. Thanks for your attention.